My name is Amar Deshpande. I'm the Vice Chair for Education for the department. For those who don't know me, and it's great to see people here live. I'll echo what Dr. Weiss often says. For those of you that are on campus, please make an attempt to come to the live portion. It's great to see people in person, in addition to the many of you that are online. So today's Grand Rounds is something that, for those of you that remember, we started last year, something called CPC, and you'll hear from the chiefs. And so last year we had the chiefs do 2 of these, and they were I think they went really well. So we're doing 3 this year. This is the first of the 3. We timed them after the medicine boards so that they can focus on this at the right time of year. And so we'll have our first 2 chiefs start, and they will be presenting a case. Really importantly, it's audience interactive, responsive. So please, whether you're here or online, you'll see a QR code a few times, and type in your answers, so and it creates basically a word cloud of answers. And we also, one of the nice parts of this is we bring in some experts along the way that are mostly blinded to the well, you can never say that to a radiologist, but who's one of our folks, but they're mostly blinded to the case. We just want to give them the amount of information so they can kind of in real time say, what would you do? And so we have a couple of our division chiefs, and actually for the first time this year, someone from outside the department. We have someone that you'll hear from who's one of our well-known radiologists. So I'll stop there. This is definitely the chief's show, not any of ours. And so I'll introduce our 2 chief residents. The first 2 who have taken on going first. So Dr. Rose Puthumana is one of our chiefs. She did her medical training at University of Missouri at Kansas City, and then came here and was in the urban health track and the pulmonary critical care pathway. And actually, for the senior residents and chiefs out there that hit submit today for their fellowship rank list, good luck with everything a couple of weeks from now. And she did a lot of other stuff that obviously led her to be one of the chiefs. So that's Rose. And Mariana Velasquez is from Columbia and came here through our Harrington program, and is one of the chiefs and is applying. So Rose for pulmonary and Mariana for endocrine. So good luck to both of you and everyone who are applying and submitting their rank list today. So I'll stop there and hand it off to the chiefs.
Hi, everyone. All right, so we have no disclosures. Just to go over the session guidelines, since I think this is the first CPC for a lot of people, this case was only known to us as the moderators as well as Dr. Deshpande. The discussants have received pertinent information to their presentation, but they have not received the diagnosis. We will periodically pause to have the discussants and the audience weigh in, so make sure you have your phones out to take pictures of the QR code and participate. Our goal is for you to learn from our experts, but not necessarily to get the right answer as we move through. And this is meant to be an open discussion, so please jump into the conversation whenever we have points for participation. And there will be multiple opportunities, so just make sure your smartphone is out.
So our patient, he was a 29-year-old male with no past medical history who comes to the general medicine walk-in clinic with new headache. So what characteristics do you want to know about the headache? You can scan the QR code. We will give you like 1 minute. Perfect, very good. Many of you mentioned like the most important things that to know about a headache, like location, duration, severity, associated symptoms, if they have prior headaches. So we're gonna go through the characteristics. We're gonna consult Dr. Sabrina Taldon.
So Dr. Taldon is an assistant professor of medicine. She's chief of general medicine and then ACMO for ambulatory services as well. So Dr. Taldon, for this patient that is a 29-year-old male with no past medical history and new headaches, can you walk us through your approach?
Thank you so much. So first of all, it's important to think about, is this headache primary or secondary? Because it's really going to be driving what path we're going to be taking with our workup. So regarding primary headaches, some of the big categories that I'd be thinking about are, is this a tension headache? Is this a migraine or a cluster headache? And the history, which many of you were putting in the Slido, is really going to help us figure out, okay, are we going in that direction towards primary or possibly secondary? And this is where the world of possibilities opens up. So intracranial or extracranial, really thinking about intracranial. We don't have any other history other than that one liner, so we have to keep the differential very broad. So I think about vascular possibilities, infectious, tumors, cerebral, something in the cerebral spinal fluid, and then there's always a catch-all. So for vascular, is this a patient who has essential hypertension that's uncontrolled? Very rare in a young patient, but stroke, a cerebral venous thrombosis, an arterial dissection, maybe a congenital vascular malformation that hadn't shown up before, an aneurysm, some sort of a hemorrhage, vasculitis, or a vasoconstriction syndrome or moya. For infectious, is this meningitis? We don't know anything about this patient's vaccination history, where they're from, et cetera, encephalitis, an abscess, septic emboli, or even toxoplasmosis. Tumors, is this a metastasis from another tumor, or is this a primary tumor in the brain? We all know our patients are Googling, and this is the first thing that comes up on AI and on Google, so that you better acknowledge that, yes, we may or may not include tumor in our differential. And then cerebral spinal fluid, pseudomotor cerebri, hydrocephalus. And then other, is this just coming from something else like trigeminal neuralgia or post-traumatic? And then the extracranial, this is where you're getting your rich history, right? Medications is a possibility, alcohol withdrawal, sinusitis, dental abscess, TMJ, something coming from the neck, like a cervicogenic disorder. Other diseases, giant cell arteritis, although it would be very rare in this young individual. Thank you.
Thank you so much, Dr. Talbot.
Yes, Dr. Weiss.
Add, not to exclude, this was great, but I would also include metabolic causes such as electrolyte disturbances can often present with headaches and hyponatremia, and of course that opens up a whole other thing. So there's some, this was excellent, but I would also include metabolic causes.
So now we're gonna mention some of the headache characteristics. So the pen time was throbbing. He mentioned that it was like holocranial. It initially like it comes and goes, but it can last up to 4 hours, and it's been going on for the last 3 months. He described that it's 6 out of 10 in the pain scale, no variation, no triggers or alleviating factors. Every time he moves, the pain is worse, and the only positive like associated symptom that he mentioned was subjective fever and body aches. So what happened with the patient? So he went to the appointment, he was ordered like some imaging of his brain, but he wasn't able to follow up due to some insurance issues. So over the next 2 years, he continued having like mild intermittent symptoms that were partially relieved with NSAIDs, but progressively worsened to the point that he had to come again to the ER. And now with worsening headache and memory loss. So the headache at this time was associated with subjective fever, chills, night sweats, nausea, decreased appetite, dizziness, generalized weakness, especially for the last 2 weeks. And the memory loss, he mentioned it was like short-term memory, and it was also associated with confusion. So let's go through his past medical history, so maybe we can get some clues here. So he was electrocuted and fell at that time with a facial trauma when he was 15. He has history of inguinal hernia repair in 2017. He's been taking ibuprofen as needed for his headache, usually 400 milligrams like 3 to 5 times per week. He doesn't have any allergies. He was born and raised in Honduras and moved to Miami 5 years ago. He lives with his girlfriend. Most of his family still lives in Honduras. He works in construction in Miami and has continued to work through the evaluation of this headache. He usually drinks 1 to 2 beers per week, denies any drugs, recreational or prescription drugs. He's sexually active with one partner and doesn't have any history of STIs. The only positive family history is that his mother had hypertension. So in the initial evaluation, his physical exam was like pretty like unremarkable. He was well appearing, no acute distress. So positive things, he did have tenderness to palpation of the temporal area and the neck bilaterally. And in neurological exam, he was alert and oriented times 4. His cranial nerve didn't show like any deficit, no gait abnormalities. Romberg, Kernig, and Brudziński signs were negative. And he remembered like 3 out of 3 on the 3-item recall test. The basic labs in the year when he arrived, like the CBC, CMP, ESR, and CRP were within normal limits. So Dr. Tardon, what you would like to do next for this patient?
I think it would be appropriate to pursue imaging at this time.
Would you like to
MRI.
have like MRI?
Yes.
Okay, we'll ask the group two. What would you all like to do next?
I'd probably start without contrast. Let's see. Let's see what the group says online.
You can specify if you want it with contrast
If
or
we're gonna
without
get the-
contrast.
Widest differential, we would probably do with and without, to be quite honest.
And maybe if we could just hear from you, like, what was the one or two things that made you and a young man go, what did you see in those previous slides that made you want to get imaging?
Yeah, we're not discharging this patient. I think some of the things that stood out to me were the fact that this patient's been electrocuted, had trauma in the past. I don't know if this patient had suffered intracranial damage back then. There's complications. I was also really piqued my interest based on where the patient's from. We don't know what the vaccination history is for this patient, and I am keeping infectious etiology on the differential, so that's one of the reasons why with contrast might be beneficial.
Perfect. Very good thoughts. We also wanted to do an imaging. So let's go to the CT brain. We did it like initially without contrast, and it showed, as you can see on the right side, a CSF density lesion in the left frontal lobe, measuring 4.2 by 3.2 by 3.1 centimeter with mass effect in the left frontal horn of the lateral ventricular system with mild enhancement in the inferior aspect of the lesion. As you can see, we didn't see any calcification, hydrocephalus, and like any hemorrhage or like midline shift. Then we have the MRI brain. You can see like the same lesion here. It is show like almost like very similar, like CSF equivalent cystic lesion in the left inferior frontal lobe, like surrounded by vasogenic edema. It also showed a tubular T1 hyperintense structure within the cyst that was measuring like up to 1.1 centimeters. So now that we have like some images, go ahead.
Wait a minute, go back to the physical exam
Okay.
and the neurologic evaluation on the physical exam.
As reported in the chart.
Yes. As it's documented.
Okay, I mean, I have to take that at face value.
Do we know, did we see on the admission one, or maybe a neurologist or an internist or someone that really did like a very like extensive neurologic evaluation? This is what we got.
Yeah,
This
that's
is
what we
we
got.
have.
Okay.
Yeah.
Yeah. So, yeah, we're going. Next. So please tell us what you're thinking now after the imaging. Someone wants to do goals of care discussion.
As a reminder, he's in his 20s.
He's very young.
He's 29.
Let's wait for the goals of care discussion.
Yeah.
Okay. Very, very good thought. So now we would like to consult neuroradiology. Dr. Stephen Falcon is a professor of radiology, associate chair of radiology, and director of undergraduate education.
Thank you, and thank you for the invitation, and I appreciate it. So I'm not totally surprised that the neurologic exam was unremarkable based on the location, but let me go over the images. And I was asked to basically present how I think through a case like this and how I come up with a differential diagnosis. So First, I'm going to show some additional images. You saw the T2 images where fluid is bright. So it was following CSF, and we have further confirmation of that on what we call a flare or fluid attenuation inversion recovery. What it is a T2 with suppression of CSF. And so you see this lesion, for the most part, almost all of it became dark like the CSF. So this is a cyst of some sort. Around it is some hyperintensity on this flare image, which could either be gliosis or edema. It's likely a mild amount of edema around this lesion. You were shown some nodules internally, and here on the T1 image, we can see one of those nodules anteriorly. And then when we gave contrast, we saw an incomplete rim of enhancement around this lesion. So how do I think about cystic lesions of the brain? Before I get there, I just want to emphasize one thing, and it was said correctly, that this lesion has no calcification. However, if you look elsewhere in the brain, there are two calcifications. One in the subinsular region and one in the cortical subcortical right parietal lobe. So that is a factor that will lead into the differential diagnosis. So this and the next slide are not meant for you to sort of look at everything here. I want to go through how I think about it, and this is my internal augmented intelligence. If I were to design an augmented intelligence algorithm, this would all be included in that algorithm and probably some more. Okay, so location, location, location is like real estate. Where is the lesion? That is important. And it's beyond which lobe or if it's white matter or gray matter. It is also, is it in the parenchyma or outside the parenchyma? Epidural space, dural space, leptomeninges, et cetera. On T1 and T2, so this lesion was in the intraaxial space. On T1, it followed CSF. T2, it followed CSF. On flare, it followed CSF, and it had a rim of hyperintensity. So this falls under the non-neoplastic differential diagnosis of a cyst, okay? And in the enhancement was an incomplete rim. There was no calcification within this lesion, but there was calcification elsewhere in the brain, and there were non-enhancing nodules within it. And when what I did was, based on location and the other all of the differential diagnoses of non-neoplastic lesions, I went through, does this lesion in this location, does it follow this signal, et cetera, and assigned it red if it didn't, green if it did, or yellow, sometimes it can. And if you look through this differential diagnosis, the only diagnosis that has every single one of these features is neurocysticercosis. Now, so this is for non-neoplastic intraaxial cystic lesions. If I add neoplasms to the differential diagnosis, pretty much, again, nothing is all green. You might consider some of these other differentials, but really not. So in my view, the only differential diagnosis that fit, and not bringing in any of the clinical, because the only thing I had was 29-year-old from Honduras. And by the way, Honduras also fits with the neurocysticercosis is, in my view, the only differential. So I think this is a parenchymal lesion of neurocysticercosis with actually lesions in the that are burnt out and calcified, and a lesion in the nodular vesicular stage. Thank you.
Thank you so much, Dr. Falcon. So we have more labs that you asked for them before. So HIV, the viral hepatitis panel, acute A through C, interferon gamma release assay, strongyloides, IgG, all of them were negative. Toxoplasma, IgG was positive, but the IgM came back negative, and the Echinococcus and Cysticercus, IgG and IgM were in process at this time. So neurosurgeons suspect that the cyst has an infectious etiology, as Dr. Falcon mentioned. And ID, where the differential was Echinococcus, as we have here. And they ordered a liver ultrasound looking for any cysts in the liver that can go more with Echinococcus diagnosis, but it only showed a echogenic appearance, likely steatosis without any focal lesions.
At this point, we'd like to call Dr. Suzanne Deblecki up to the stage for an infectious disease consult. She is Professor of Medicine and Chief of Infectious Diseases, as well as Director of HIV Prevention. Thank you, Dr. Deblecki.
Thank you. So for those of you who believe that every headache deserves a great deal of respect, this one is for you. And I also had little information here. So a 29-year-old man from Honduras with headache and a cystic brain lesion. So I put a broad differential diagnosis, but I think Dr. Falcone already narrated it quite a lot for us. But just to think about first space occupying brain lesions, and the list is quite long. As was mentioned now, and we didn't necessarily know this before, but I did assume that we think that this young person is immunocompetent. And I think that's really important because the first thing that we can do is cross off a lot of things that are really common or are prominent only in people who have significant immunocompromise. Doesn't mean we can completely rule them out, but certainly they go way down on the list. And immunocompromised patients also will be more likely to have atypical presentations of things. So, when it makes the differential much more straightforward when we don't have that. The most important acquired immunocompromise that we see at Jackson is HIV disease. And so I was glad to see that he had an HIV test. Everyone should have an HIV test who's admitted to the hospital, truly. And everyone should have one at least once in their life, if not more. That's the recommendation. So we don't believe that this young man is living with HIV, nor did we learn that he has any exogenous immunosuppression. So I think we can cross a lot of things off the list here. And then, other things that are important to know when we're thinking about abscesses and metastatic infectious disease, right? Infectious disease that started elsewhere, started in the bloodstream and ended up in the brain would be injection drug use or recent medical procedures. We don't have any of those mentioned. So I think we can eliminate a few things. And then, it really does come down to epidemiology and history, right? And we have some of this that he does have some suggestive epidemiology being from Honduras. He's been here for 5 years. His symptoms have been going on for 2. That also tells us something. So we can narrow our diagnosis further along with the cystic appearance on imaging, which is hugely helpful actually. So most of the things that we started with are really tend to more present as solid lesions. I've included a lot of things here, but without a lot of refinement of what we mean by cystic imaging as Dr. Falcone just went through. So there are a lot of things that may not typically present as cystic, but are common enough that we want to think about them having a cystic appearance. Tuberculosis with cavitation can look a little bit cyst-like, but not quite like that, but it can be a little bit cyst-like. And then when you go down to the parasite range, we do have the things that more commonly present as truly cyst-like. And I've listed some of them here. I think that epidemiology again becomes very important when we're thinking about neurocysticercosis. We think about pork ingestion, but really that's not the thing, right? It's the tapeworm shedding from someone who has ingested some pork, and then anybody can get it. It's really person to person spread, but typically, and it's extremely common in Latin America. With about 30% of people who present with seizures will have that. Other things here are less common, and we would want to have specific epidemiology to point us to that. So here's what how I would narrow it with cystic appearance. And then when you have the presence of a single scolex in a cyst, so the scolex is sort of like the head of the worms is attaching there. And that is very characteristic. So I think once we see something like that, my first thought is go to my neuroradiologist, go talk to Dr. Falcone. Are you seeing what we think we're seeing right there? If they can really say that this, yes, looks like a scolex inside of a cyst, you're really down to one diagnosis. And this would be our patient sharing with our future Health and Human Services Secretary, neurocystis, or brainworm, as he called it. Yeah. Thank you.
These slides were made pre-election, just for everyone.
They were. We also asked ChatGPT, along with our consultants, what they thought about these imaging findings and headache characteristics. ChatGPT agreed with our consultants and thought that neurocysticercosis was the most likely diagnosis with all the imaging findings and the clinical presentation. I will also say that ChatGPT actually got more information than our consultants because we did give him all of the imaging as well as the rest of the clinical presentation.
I also, if Dr. Falcone could just comment on that variant.
The racemose cysticercosis does not have a scolex, and it's in the leptomeninges, which I think it's saying here. It usually, I don't know that I've ever seen a case in the parenchyma, but when you see a cyst without a scolex, it's just in a different phase of the life cycle. And I don't think it's called racemose at that point, but I mean, in general, it got it right. If that's what it is.
It's not quite Dr. Falcone yet, but it's getting there.
And this is why we talk to neuroradiology and not just ChatGPT.
So for the hospital course for this patient, so he was transferred to IMCU and he started on dexamethasone because it was a concern for development or increase intracranial pressure after we started antiparasitics. After 24 hours of being on steroids, he also was initiating albendazole 600 milligrams twice a day, praziquantel 1200 milligrams 3 times a day. Neurosurgery deferred sampling and drainage because they were concerned about disseminating this parasite infection through the basal cistern and causing like maybe severe aseptic meningitis. Over the next day, his headache gradually improved and we got like subsequent labs. The Quinococcus IgG came back negative, the Cysticercosis IgG came back positive. After further history, so the patient had been working on a pig farm for a long period when he was in Honduras, but he's been here for 5 years working in construction, so maybe that's why we didn't have like this relationship. On this chart, he was switched to oral prednisone, which was continued for 14 days where he was on the antiparasitic, and it was followed by a rapid taper over 7 days. 6 months after discharge, the patient like really noticed like improvement of his symptoms, and the MRI brain showed like significant reduction of the size and the cystic lesion. Dr. Falcone, can you walk us through this MRI before and after treatment, please?
Yeah, I think this picture tells 1,000 words, right? I mean, you can see the dramatic reduction in size of the cyst. So a great response to the therapy. And, you know, when he initially presented, this was much larger. This was sometime after, much smaller, sorry, than this picture or image. So I'm glad to hear that his symptoms improved. I do have a question for you. And I, you know, back in the day, they would always do an eye exam before initiating therapy. So I was just wondering if this patient had an eye exam. Yeah, apparently on the medication, if there are cysts in the eye, if they die, they can cause a problem with vision.
Yeah, he was evaluated by ophthalmology before initiating therapy. Thank you.
Tell us what specifically were they looking for?
They were looking for a cyst that was in the brain. Maybe he was having like another cyst over there that we didn't see.
What was the rationale for the follow-up, the timing of the follow-up MRI? Is there an accepted period of time? 6 weeks, you wait several months, Or was it just a matter of you couldn't get the patient? Or-
So usually they do the follow-up MRI in 6 months after treatment, but they do clinical follow-up, like periodically.
Actually, Dr. Deblecki, in your practice, is that typically 6 months?
Yeah, I mean, I think it depends on the clinical course of the patient. And actually the duration of treatment also depends a lot on the clinical course of the patient. And so even though, oftentimes you'll see 14 days of combination therapy, a lot of the longer term management is about managing the inflammation. And we do have quite a few folks who come back and require multiple courses. We give antiparasitics, but it's probably the anti-inflammatories that are more important. And if they're having symptoms. So if he has a recurrence of symptoms, we would image more quickly. It also depends on the extent of the disease. And we haven't seen, I guess, I'm a little thrown, but I wouldn't say that this is necessarily Racemose disease. If I had someone with Racemose disease, I would image them a little bit sooner and keep a closer eye on them. But I think for this person, 6 months is probably reasonable.
Is there any comment, Dr. Falcone, on the, doesn't look like there's much edema initially. And so the anticipated edema is in response to
It's-
the treatment, the death of the parasite in the,
Actually, even without treatment, so there's a natural life cycle even without treatment. So as believe it's when the scolex starts to die, there's an inflammatory response and edema.
that, no.
And just to the point, Dr. Falcone, on that chart where you had all the checks and X's, echinococcus, which was the other, I think, primary working diagnosis that ended up being negative, was almost all green, right? There was only one or two things that were not.
Yeah, it was my second differential diagnosis, and the fact that we saw what looked like scolices in it. I actually saw two, and so this may have been a septated or two separate cystic lesions within the brain. But yeah, it wasn't a differential diagnosis. It was my second.
Yeah, that was the second differential for ID. So when they started treatment, as you remember, like they didn't have the echinococcus or the cysticercosis like serologists. So they said, like, let's start treatment and we will define the duration based on the antibodies. And they decided 14 days instead of 28 because it was like neurocysticercosis.
Last question for me, the I related in patients from Honduras that might have been exposed, or is that in fact diagnostic of an active infection?
So it only tells you about exposure. It does not tell you about whether this is the active infection that that is related to the lesion that we're seeing here. I mean, obviously that would be the supposition. And actually though, if you do have someone who if you can define a scolix in the lesion, even if that cysticercal serology were negative, I mean, it's considered pathognomonic. So really the cysticercal serology helps you more when you have in between lesion or there's more uncertainty in the diagnosis. I think it's nice that it's positive, but I think that the diagnosis actually here is pretty certain if you do have a really good look, which you don't always have of the lesions and the scolix. Echinococcus is a reasonable consideration, but much less frequent in the brain. And usually with more specific epidemiology that we haven't received.
And I don't know if I hit enough on this point, but the appearance of neurocysticercosis changes based on the stage of the disease and where it's located. So the racemose looks different from the parenchymal.
Thank you for your participation. So to summarize the case, this was like a 29-year-old male with Honduras, no past medical history, who came to clinic because of headache. CT and MRI showed like a cystic lesion. Was started empirically treated with dexamethasone, albendazole, and praziquantel for suspected like neurocystic sarcosis versus like echinococcal infection. Headache improved after treatment. We got like the cystic sarcosis IgG back after like starting treatment. And as we said before, it's very important to get a history because this patient was a pig farmer and he was eating pork like every day before coming to the US. So he had this positive, this clue that we can lead us to the diagnosis. We prescribed the antiparasitics for 14 days and he improved like in imaging as well after treatment.
So as far as our learning and teaching points, we'll do a quick review of neurocystic sarcosis, its manifestations, and its diagnosis. Many of our learning objectives actually have already been covered by our consultants, but we'll understand the common clinical manifestations of neurocystic sarcosis and also review the workup and the diagnostic criteria. So just for some background, cystic sarcosis is caused by the larva stage of the Taenia solium tapeworm. Its life cycle, as we had kind of begun to discuss, starts out with the eggs or the proglottids in feces that then get passed into the environment. Cattle or pigs become infected by ingesting vegetation that has these eggs. These oncospheres then hatch and they penetrate into the intestinal wall and they circulate through the musculature of the animal. And they'll develop into cysticerci within the muscle of the pig or the cattle. And then humans become infected by ingesting the raw or undercooked infected meat most of the time. Within the human body, the scolex will attach to the intestine, and then they grow into adults within the small intestine. So as far as clinical manifestations, the cysticerci will initially attempt to evade host immune responses, and they will lose this ability as they mature. So your host immune response can initially appear as contrast enhancement or edema on radiographic imaging, and this inflammatory response is often clinically frequently associated with seizures. As your host response progresses, the parasite will begin to degenerate, as we sort of talked about, and the cyst fluid will get infiltrated with host cells, and then it'll appear more dense on T1 MRI as well as CT scan. As the disease progresses, the cysticerci will either resolve or they become non-viable calcified granulomas. Calcification at this stage can also result in seizures clinically. This can present as multiple or single lesions. From an epidemiologic perspective, in India and in the US, it's more common to see single lesions. In Latin America, it's more common to see multiple. So of course, in Miami, we see both single and multiple as a variant. As far as clinical manifestations, it depends on if the lesions are intra or extraparenchymal. For intraparenchymal lesions, you're more likely to see things like seizures and or headaches. Extraparenchymal lesions will present with symptoms of elevated intracranial pressure, like headaches, dizziness, nausea, vomiting. As far as the diagnosis, this should be suspected in patients who have seizures or any manifestations of increased intracranial pressure, as well as the epidemiologic exposure. So you need both the exposure as well as the neuroimaging findings to make a diagnosis. This is the diagnostic criteria from UpToDate as well as the infectious disease societies. There are multiple combinations that you can have as far as absolute criteria, neuroimaging criteria, along with epidemiologic exposure, but importantly, you do need things from multiple categories to make a definitive diagnosis. As far as treatment, this we also sort of touched on. For patients with 1 to 2 viable cysticerci, albendazole monotherapy for 10 to 14 days can be appropriate. If they have more than 2, then that's where we combine albendazole with praziquantel for, again, 10 to 14 days with adjunctive corticosteroid therapy. But as Dr. Dublecki had mentioned, this length of time for treatment will really vary based on clinical presentation as well as imaging findings. Thank you all so much for your participation, and if there's any other questions, we're happy to take them.
Anything in the chat? Can you comment about what's considered active versus inactive neurocystic sarcosis? And as you're working up a patient and how that affects treatment?
So you mean about the antibody, like IgG or IgM?
Well,
Or-
is there just more referring to for those that are going to be doing questions later?
I mean, really, if they're clinically symptomatic and if they have the neuroimaging findings as well as the exposure, then you would need to treat them. So, I mean, if they meet any of this definitive diagnostic criteria, they would need the treatment. And it'll depend on if they have one versus multiple lesions.
I mean, I think, you know,
we were discussing earlier about viable versus non-viable or kind of dead lesion, and I think there's a progression that happens from the initial infection, and typically radiographically it does evolve over time, all the way from sort of a more clear cyst to, I think, non-radiographically, but sort of like cloudier or more dense, and with the scolix, and as that the immune system kicks in and it starts to degrade, the parasite dies, and you end up getting more inflammation at that point, and then eventually calcification. So that's, it's hard to say exactly when it becomes non-viable, but certainly calcified lesions would not be considered viable. But I think the thing that changed over the years is that we do treat, when people present with seizures and suspicion, and we think it's cysticercosis, we do treat them. Whereas I think years ago, that was not necessarily the case. It was more just treating the seizures rather than with antiparasitic medications.
Dr. J from the chat had one question, and then Dr. Weiss. Dr. J, are you able to unmute, or do you want me to ask?
No, I can ask, is it common to have a normal CRP in this setup case?
Not from what we saw, but again, I think it depends on what part of the life cycle, I would assume. So if the cysts are now non-viable, if they're calcified, I would expect the CRP to probably be lower. But actually, Dr. DeBlecki, if you don't mind, from your experience, I don't know what you've seen. Sorry to call on you so many times today.
Right. Hi, Jay. I mean, CRP is a general inflammatory marker. I think, you don't necessarily have to have systemic inflammation in these patients who have isolated lesions in the brain. I really can't say, I don't know if you looked at CRP across many patients with neurocysticercosis, what you would see, but I guess it doesn't entirely surprise me that there's not a lot of systemic inflammation.
Thank you. Yeah, I also was just thinking the same line. Thank you.
So two questions. First, from a public health perspective, is there any education that you need to do in terms of his he's not working on the pig farm anymore, but he is living in a home, presumably, and preparing food, perhaps, for some of the people with whom he lives with? Is there any prophylactic or education that needs to be done with regard to that? And subsequently, how fastidious does one need to be at the time of diagnosis for looking for cysts elsewhere in the body?
So for the transmission, the most important thing is like the hygiene that they do with the pork when they have to eat it. Like we don't know how they were cooking it when he was in Honduras. So it's important to consult on that for the patients here. As far as transmission, like he got treatment. So we were not concerned that he might like infect like other family members.
I think also fecal oral spread is an important thing to consider. So I mean, hygiene when cooking to prevent any kind of fecal oral spread, same things as with like hepatitis A or some of these other diseases, I think would be important. So hand hygiene, kitchen hygiene.
Right. So his probably his home exposures have their proof that they've already been exposed to this. And the second question was
To look for lesions around the rest of the body.
Cysts elsewhere in the body further eradicated.
Any idea, Dr.
I think we
Doblek,
may have to consult ID
Yeah,
for
we
this
have to call
question,
ID.
actually. Yes, please.
Okay, this is on, right? Okay. I guess just to the point about screening for the tapeworm, right? Because remember that for cysticercosis, you do have to, a lot of it is human to human spread. So in non-endemic areas, certainly if you have somebody who's presenting with neurocysticercosis, you would want to screen their close contacts for the tapeworm. So if you ingest the meat, then you can become infected with the intestinal tapeworm, but then it's the shedding of those eggs and fecal oral can be auto-inoculation or to your close contacts that will result in the cysticercosis. So there is a role, and I think that it's not unreasonable to screen household contacts for tapeworm, an OMP. So just to finish that line of thought. And then as far as screening for other sites, I think that especially if you have racemose or bacil, like in the lower brain, you would want to look at the spine as well, because that's actually quite common to have spinal cysts. And same thing as with the eye, once you start treating and get inflammation, you can have, significant exacerbations that can worsen or cause new symptoms. So not necessarily in this case, but if you do see that, then it's important to do that screening.
One more comment from Dr. Falcone.
The literature talks about spinal involvement, and I'm a spinal cyst guy, and I will tell you, I've never seen a cysticercosis in the spine. So I'd be interested if we have cases, looking at that.
Yeah, so we have had at least one case who had but really significant racemose cysticercosis and also spinal cysts. Yeah, yeah. So it has happened at Jackson, but just about everything has happened at Jackson. So
Repeat the question.
asymptomatic screening guidelines. In general, you mean for brain imaging? No, I think it's been discussed in when there's a lot of prophylactic treatment happening. And the idea of you don't want to cause symptomatic disease in people who had undiagnosed, but it's not something that we in non-endemic settings, certainly it's not something that we do.
Okay, Dr. Deshpande, do you want to adjourn? Or, yeah, last comments?
No, thank you guys very much. And we hope you guys enjoyed the CPC. We have another one coming with 2 more chief residents, no pressure, in a couple of months. So thank you guys.